السلام عليكم ورحمة الله. أنا دكتور محمود المعتصم. نحن متواصلين في تجمع الأطباء السودانيين في الولايات المتحدة سابا في سلسلتنا للمحاضرات اللي بنحاول فيها نناقش مرض الكوفيد من أوجه متعددة. الليلة محاضرتنا عن الكوفيد 19 وتخصص القلب، COVID 19 and Cardiology. حنناقش فيها المرض من منظور الكارديولوجي ونحاول نقدم معلومات لا علاقة بالموضوع. معاي حيكون نخبة من أميز الأخصائي القلب هنا في يعني من عضوية سابا. داير في البداية حيي الأطباء في السودان، هم خط الدفاع الأول وربما بيشتغلوا في ظروف صعبة، لكن هم بيقوموا بمهمة يعني كبيرة جدا جدا في الصحة ويعني رعاية الصحة وإنقاذ الناس اللي بيكونوا في المستشفيات، فنحن دايرين نحييهم. داير أذكر الناس إنه المحاضرة حتكون موجودة يعني كفيديو في صفحتنا، ممكن الناس تنشرها للأطباء والكوادر الصحية في السودان لاحقا. والتقديم البرزنتيشنز اللي حتتعامل هنا برضو حنخليها تكون متوفرة في لينك في البوست بتاع الفيسبوك. برضو داير أذكر الناس إنه في نهاية المحاضرة حنستقبل حنجاوب على الأسئلة، يعني فالناس ممكن تضع الأسئلة بتاعتها في التعليقات ونحن بنجاوب عليها لاحقا. أنا حابدأ بإني أعرف دكتور خضر عثمان. He is an Interventional Cardiologist and Clinical Professor of Medicine at University of Arizona. He's the Director of Heart Center at Yuma, Arizona. مرحبا بك دكتور خضر.
Thank you, Mahmoud. I would like to thank SAPA for this opportunity and this series of lectures about COVID-19, and I'm delighted to join this elite group of cardiologists in presenting some of the data and the information about COVID-19 and cardiology.
شكرا لك. معانا برضو دكتور مصطفى محمود حسن. He is cardiac electrophysiologist and assistant clinical professor of medicine at Michigan State University, and he works at the Heart Rhythm Clinic of Michigan. مرحبا بك دكتور مصطفى.
عليكم السلام محمود، شكرا على الاستضافة، وأحيي كل الحضور والأخوة الزملاء اللي حيكونوا مشاركين في اللايف دي، وأحيي تجمع الأطباء السودانيين في الولايات المتحدة على إتاحة الفرصة عشان to share some of the experience وتبادل الخبرات مرات. شكرا جزيلا.
شكرا لك. برضو معانا دكتور أحمد صلاح الكجم. He is an interventional cardiologist at San Bernard Heart and Vascular Hospital في أركنسا. مرحبا يا دكتور أحمد. أنت ميوت بس if you can unmute. يا دكتور أحمد if you... yeah. okay. I think إنه عندنا مشكلة في الصوت يا دكتور أحمد، نحن ما سامعينك لسه. نحن ما سامعينك يا دكتور أحمد. لو ممكن بس تعمل ريفرش للبراوزر وتخش ثاني، أنا في المسافة دي هعرف دكتور خضر دلوك. سوري يعني على المشكلة التقنية. دكتور خضر دلوك he's a cardiac electrophysiologist at Portland VA Medical Center, and he's an assistant professor at Knight Cardiovascular Institute at Oregon Health and Services University. مرحبا يا دكتور خضر.
مرحبا بك محمود، شكرا لكم والشكر لتجمع الأطباء السودانيين بالولايات المتحدة سابا لإتاحة الفرصة. أحب برضو أشكر يعني جميع أطباء بلادي الجيش الأبيض داخل وخارج السودان، وتحية خاصة لأطباء القلب داخل وخارج السودان، وشكرا جزيلا.
شكرا لك يا دكتور أحمد. هل الصوت صلح؟
كيف سامعني كويس مع متصل يا محمود؟
يس.
تمام. طيب مرة ثانية السلام عليكم ورحمة الله تعالى وبركاته، ومرحبا بالجميع، مرحبا بمحمود وزملائي الأعزاء هنا في أمريكا وفي السودان وفي كل أنحاء العالم، ويعني تحية كبيرة لكل الكوادر الطبية اللي بتحارب الوباء ده، وإن شاء الله ربنا يحفظكم.
شكرا. طيب انا حادي فرصه لدكتور خضر انه يبدا يكون يعني المتحدث الاول معنا.
شكرا محمود. Thank you my colleagues. I would like to take this opportunity again to thank Saba, the physician in Sudan and those in the United States, and also all those who are following us. We would like to welcome you to this, and we're looking forward to your interactions. Can I have the first slide, please?
Yeah.
So COVID-19 and cardiovascular diseases is a very important topic that we would like to cover today. This disease is caused by SARS coronavirus 2, which is initially started in bats, and then it went through an intermediary mammals of unknown origin, and then it went into human. And our colleagues in surgery, ICU, and several other specialties have spoken, and we are going to continue to talk about the cardiac aspects of COVID-19. This is a pandemic, the likes of which we haven't seen in over 100 years. All these green colors are the numbers of countries that have been involved or got infected. This is over 180 the last time I checked. So it's a huge pandemic. It affected not only morbidity and mortality, but it affected also the way we live, the way we work, and it affected the economy of so many countries across the world. If you look at the number of cases worldwide, there's about 2.3 million cases worldwide. If you look at this and zoom, you can notice that this is particularly common in Europe and in the United States. In fact, the United States already exceeded the 700,000 mark, and the number of cases that are positive in the United States actually are more than the 4 different European countries, Spain, Italy, France, and the United Kingdom. So this is a comparison between the United States and Sudan. Obviously, we're lucky in Sudan to have only 50 cases. There are only 10 people who are deceased. And if you compare that with the United States, there are over 700,000. I've just checked it this morning. It is very important for me to point now to the people in Sudan that this is good news, but we're not home free. It is so important to prevent this disease from happening, simply because we do not have the facilities, physicians, PPE, which is protected gears, that are available in other countries. And so I would like to tell all the people of Sudan to please observe distances, stay home, wash your hands with soap and water as much as you can. Avoid تجمعات بتاعت الزواج as much as possible, because we don't want this to get significantly increased because we don't have the facilities to handle it. So we have to know something about this virus to be able to understand and maybe contain and treat it. And so this is a biomedical talk from a cardiologist, so bear with me. The virus has an envelope. That envelope has two bilayers. One is hydrophilic and the other is lipophilic. And that is why, by the way, soap and water and detergent take care of the virus. It kills the virus. So this is a weapon that we all have, and we should take advantage of that. It's an RNA virus. It has some E proteins, M protein, and what we call a spike protein, which is going to be important in later talk. This is a busy slide, but it's so important to discuss it. Now, as I told you earlier, the virus has a S protein, it's called the spike protein. And all the cells throughout the body, including the lungs, particularly the lower respiratory tract, the myocardium, the GI tract, and the kidneys, have what we call ACE2 inhibitor, angiotensin receptor, angiotensin 2 receptors. These are found on the surface of the cell. The virus has this S protein. Once it attaches itself to the ACE2 receptor, it literally opened the gate for the virus to come inside the cytoplasm. Once that happened, it literally hijacked the metabolism of that particular cell. The virus contains an RNA genome. And we know from biochemistry, once the RNA is spilled inside the cytoplasm, it starts manufacturing from the nucleosides through a process called translation, many RNAs. And so all of a sudden, you're developing almost millions and millions of viruses. And then if you look at the right side of the slides, all these viruses go outside the cell through a process called exocytosis. And this is how it damages the cell directly, and it also results in numerous and many viruses that can then go into other tissues. The high risk of severe disease that happened to COVID. In other words, if somebody has hypertension, and I'll show that in another slide, coronary artery disease, diabetes, and heart failure, those are the people who are vulnerable to bad outcome. And we will see that at a later slide. So here it is, the comorbidities associated with hypertension, you can see, and it goes down, diabetes, ischemic heart disease, chronic lung disease, and so on. So this is a study that was done in China as well as in Italy. All these comorbid conditions are associated with increased mortality, and therefore we have to control these factors or these diseases. So how does the virus affect the myocardium? If you look at the bottom portion of the slide, there's three ways in which it does that. It increases the risk of myocardial infarction, it increases the risk of heart failure, and also arrhythmia. And there are so many different mechanisms that will result in these things, starting from direct infection, as I've mentioned to you already. There is an important aspect of hypercoagulability. There's a lot of small thrombi, whether it's in the lung, the heart, the kidney. These will lead to plaque rupture and increase the risk of myocardial infarction. There is also the oxygen CO2 exchange in the lungs because of the destruction in the lower respiratory tract that will result in hypoxemia, that will lead to myocardial oxygen supply, lead to heart failure, myocarditis, if you look at the right side of the slide, as well as direct invasion, can also result in necrosis of the myocardium and arrhythmias. So there are so many mechanisms that will result in three things: arrhythmia, increased heart failure, and increased myocardial infarction. It's a study from Wuhan where they took over 1,000 cases, but they eliminated some of them. And if you come down to the bottom of the slide, there are 416 cases that ended up dying. The cardiac injury happened in about 20% of those. So it's about 82% of those of patients who died have cardiac injury. There is also a study from Toronto, similar number, 17 to 20% in autopsy patients were found to have myocardial disease. So the association of cardiac injury with mortality in hospitalized patients with COVID-19 in Wuhan. If you look at the beginning of the slide, there are 334 cases without cardiac injury. Up to 21 days, 319 of those were alive. So the survival rate is about 92. If you have cardiac injury on the other side, 50% of those die. So this is a significant mortality associated with cardiac. Without cardiac injury, 93, 94% survival. With cardiac injury at 15 days, 50% mortality. So this is a case that it's not mine, but if you look at the EKG, clearly there is ST segment elevation in lead 1 and AVL, and a significant so, about 3-4 millimeters. Before COVID, this person will go to the cardiac catheterization without any question. And that's exactly what happened even in the COVID area at the beginning. The coronaries are completely normal of this particular patients. Of course, they didn't know that going in. And later on, the troponin, which comes after 1 or 2 hours, was completely negative. If you look at AVR, you can see that there is ST segment depression and PR elevation. That is fairly consistent with pericarditis. Of course, that was not known until later. And so in the era of COVID-19, I think we need to take a backseat a little bit and start thinking twice before we take the patient to the catheterization. So now I'm going to turn over the phone to my colleague, Dr. Ahmed Al-Kajam Ahmed.
شكرا جزيلا دكتور خضر عثمان. So I totally agree with you. Before the COVID era, this would be a very simple, straightforward case. As we look here at the ACCHA, the treatment of acute ST elevation myocardial infarction. We see that the flow chart clearly tells us if the patient presents to a hospital or a facility that has primary PCI capabilities. So this is the treatment of choice. You go to the cath lab and you open the vessel as soon as possible in less than 90 minutes as per recommendations. While if the patient presents to a hospital that does not have primary PCI capabilities, then you look into the time in to time out, or door in to door out time, which if it's less than 30 minutes, then what you need to do is to administer thrombolytic therapy in the emergency department, and then right away you transfer the patient to a PCI capable hospital. If you can get the patient to a primary PCI capable hospital in less than 120 minutes from first medical contact, then the recommendation is to send the patient to a primary PCI hospital, since we know from previous trials that primary PCI is superior to thrombolytic therapy. So this was before the COVID era, and it's still the same. The recommendations are still the same, but as you said, we need to kind of look at each individual case and look into what's the most logical next step. So this slide, this is a flow chart. This is some data that came from China. Of course, they saw the most patients early on in the pandemic. And this is by no means a guideline or something that everybody needs to follow, but this is just a way of thinking about ST elevation MIs in this COVID pandemic. So if you suspect that there's an ST elevation MI in your patient, first question you ask yourself is there any other possibilities? So is this myopericarditis? Is this a spasm? Is the patient having symptoms suggestive for sepsis or some other etiologies going on? So if the answer is no, and this is most likely to be a true ST elevation MI, then you look into the duration of symptoms. So if the patient had symptoms for more than 12 hours, then the benefit from thrombolysis is less. So if they had their symptoms in less than 12 hours, then the recommendation is to go ahead and thrombolyze the patient in the emergency department. And once that is done, then if it's successful, which means that the patient had resolution of ST elevations and resolution of pain, then the patient has to be transferred to a COVID-19 designated unit where everybody wears PPEs. There is negative pressure in the rooms. Now, if thrombolysis does not work, so the patient still having ST elevations, then the recommendation or the suggestion is you should probably take the patient to the cath lab anyway with everybody in PPEs to protect your staff and yourself. Then after all these are done, you want to screen the patient clinically and then do COVID-19 testing if it's available. And if the test is is negative, then you continue your therapies as usual. And if the test is positive, then they get admitted to the designated unit. So the flow chart we just looked at is from China, and we're just comparing this to another flow chart or another protocol from a local hospital. This is actually where Dr. Khidir Usman works. Same, very similar approach to patients with ST elevation MIs. They get categorized in 3 different categories. The first category is a low probability on the right side of the slide. And if it's low probability, then you continue their therapies the same way you would do before this pandemic, which is primary PCI. Now, if they have moderate probability or high probability for COVID-19, then it's really at the discretion of the cardiologist and what's the clinical situation. So you do still have the chance of going to the cath lab, but with full protective gear. That's the most important point: is protect your staff and yourself, and also your patients, and in the cath lab. Or you can go for thrombolysis. And again, reevaluate the patient after 60 to 90 minutes. And if your thrombolysis is adequate, then you continue testing them and screen them for COVID-19. And if it's not adequate, you go to the cath lab. So very similar protocols all over the world right now. Just to brush on the thrombolytics, our colleagues in Sudan are probably very in tune with using thrombolytics. In the United States, thrombolytics are used less, but they still play a very large role. Actually, in most rural hospitals, this is what we use. Now, if we look from the bottom to the top, you have streptokinase, which is the most commonly available thrombolytic agent in Sudan. And then there's tenecteplase, which is used more in other countries. The moral of this slide is streptokinase is a long infusion. It's a 60-minute infusion, while tenecteplase is a single infusion or a single bolus that takes about 5 to 10 seconds to give. So different institutions will have different agents, and the easier the administration is, the better and faster you can thrombolyze your patient. And before you administer thrombolysis, you should probably think about this table. This table is very important. You have to look at your patient and make sure that they don't have absolute contraindications for thrombolysis, which is basically anything that can make them bleed, especially in their brains. So any prior intracranial hemorrhage or known malformation, neoplasm, if they had a ischemic stroke less than 3 months ago, or you have suspected aortic dissection. This is very important since the presentation can be very similar, or any recent injury, head trauma, or any bleeding problems. Now, the relative contraindications will become less important in these kind of situations, since we're more pushed towards thrombolysis in many cases that are COVID-19 positive, but you still have to look at them. So this is about STEMI. About the non-STEMIs are actually somewhat easier, and this is kind of a busy flow chart. But the whole idea from this flow chart is you have to evaluate the patient clinically and use your clinical sense, but also use your risk stratification scores like the TIMI score, the GRACE score, and basically also screen them if they have COVID-19 or they're likely to have COVID-19 infection. And then depending on their clinical risk from their NSTEMI and their COVID-19 status, they're either high risk NSTEMI or low risk NSTEMI. And if they are high risk NSTEMI, then you start your therapies as usual, your antiplatelet therapies and your anticoagulation, and then either admit them to the CCU for further testing, or you can go to the cath lab for PCI, angiography and PCI if they're in a high risk patient who continue to have chest pain despite medical therapy, patient who has electrical instability or hemodynamic instability. On the other hand, if they're low risk, so if your medical therapist has controlled the symptoms and they're very stable from hemodynamic and electrical standpoint, then it's very reasonable to send these patients home if they're COVID-19 positive to finish their treatment at home, or even treat them in the ward until they're tested, until you make sure that they're not positive for COVID-19, and then decide for further treatment. So this is really the summary of this flow chart, is you have to clinically evaluate and assess the patient and then make a decision. Now, this is really a topic that is rising these days, and that's the myopericarditis in COVID-19 positive patients. This is a case of a 53-year-old female who had no previous cardiovascular disease or risk factors for cardiovascular disease, presented with fatigue. So it's worth mentioning that she didn't have any respiratory symptoms, no fever, no cough, and her EKG is on the top panel. And if you can see it, it's kind of small and subtle, but there is mild or minimal ST elevations in the inferior leads, so 2, 3 and AVF, and there's a slight depressions in AVRs and AVL. In any case, this did not really qualify to be called a ST elevation myocardial infarction, and hence she was treated as usual medically. She was admitted, and then her cardiac markers came back elevated and abnormal. Once that was known, she had an echocardiogram that demonstrated that her ejection fraction was reduced, and the diagnosis at this point was not very clear. So the suspicion was for myopericarditis, and she went for a cardiac MRI. So if you look at the panel in the middle, this is a short axis and a 4-chamber view of the heart on the cardiac MRI. And sequence, in this specific sequence, you can notice that the myocardium is thick, so there's increased thickness of the myocardium, and there's also a diffuse increased intensity of the signal. So all this bright color in the left ventricle and also some of the right ventricle is increased intensity in the signal, and this is a marker for edema. So this is edema and hyperemia of the myocardium that is very diffuse. Then if you go to the bottom panel, the last 2 pictures, again a short axis and a 4-chamber view of the ventricles, and there's also increased intensity. Now this is a late enhancement. This is after 10 to 15 minutes after gadolinium was given, and this is a hyper enhancement that is delayed. So this is your marker for necrosis and cell damage. So if you go through this again and you think about it, these are the 3 cardinal signs for inflammation. So you have hyperemia, swelling, and cell necrosis. So this is convincing for myopericarditis. Now you have to be careful in calling every elevated troponin with some chest pain myopericarditis in COVID patients, because really the diagnosis is either by MRI or by endomyocardial biopsy, which is really falling out of favor. But this is a hot topic. This needs to be investigated more to see what's actually the incidence of myopericarditis in COVID-19 positive patients. Just quickly, if you do go to the cath lab, safety is the most important thing. So keep the procedure short and simple. to reduce the chances that you might go into complications. If you need to intubate the patient, if the patient has respiratory problems and you think this is going to get worse, then you should probably intubate outside of the cath lab because it's easier, it's more controlled, and also if you have multivessel disease, it's better to PCI the culprit lesion, only also reduce your time in the cath lab. Now, this is another patient. This is a CT scan with a IV contrast of the chest, and on panel A, on picture A, you can see there is this peripheral ground glass diffuse infiltrates that we see in COVID-19 patients, and there's also some vacuolar sign and vacuoles in the where the black arrows are. In picture B, you see some fibrous stranding, and then in C, in picture C, there's dilatation of the pulmonary vasculature there, as illustrated by this black arrow. Now, what we're interested in is picture number D, or panel D. So in this picture, the white arrow points towards the middle, the right middle lobar artery, and the gray increase in intensity signal is a pulmonary embolus. It's kind of interesting. It's very interesting that this this thrombus or embolus is in an area where the parenchyma is actually healthy. So you don't see the inflammation that you saw in the periphery. And this kind of suggests that this did not happen because of a local inflammation, and this is rather a thromboembolic event. So it came from probably the lower extremities. Now, if you look at this slide here, we're more and more convinced that the data is just saying that COVID-19 infection is a hypercoagulable state, no matter what the intensity of the disease is. And there is limited data that's coming from Europe and China that suggested that the pulmonary microvascular thrombosis might actually play a role in the progression of respiratory failure, and it's causing more of the increased oxygen demands in these patients. There's actually an autopsy series, I think 4 or 5 patients that were in post-mortem examination. They looked in their pulmonary vasculature, and there was multiple fibrin and platelet thrombi. This might suggest that in a selected patients, not every patient is a candidate for this, but in selected patients where you think there is a worsening of their situation, a clinical picture, or they go into multi organ failure because of severe COVID-19 ARDS, you might want to get their CT scan with IV contrast. So you look for thrombosis. Now, this is also data coming from a hospital in the Netherlands. This is more than 180 patients who were in the ICU, so critically ill, and they looked in the cumulative incidence of venous and arterial thrombosis. And what happened is they found that their incidence of thromboembolism is more than 30% in these patients. Most of these cases were actually pulmonary emboli, while some of them were isolated deep vein thrombosis or cerebral infarcts. So really high incidence of thromboembolism. When they looked at the D-dimer, this is from Wuhan, this is from China, they looked at the D-dimer elevation and trends in patients who survived and patients who didn't survive in the ICU. And as you look here in the blue line and dots, the patient who survived did have some elevation in their D-dimer, but it was a constant and not rising elevation in the D-dimer levels. While patients who did not survive, they just had steady and progressive elevation of the D-dimer, and these are patients who did not survive. So one might think we should probably add the D-dimer to troponin levels in patients with COVID-19 as one of the poor prognostic findings. And finally, given all these findings and that COVID-19 is a hypercoagulable state, there's many institutions all over the world that now adopted a more aggressive DVT prophylaxis for these patients, where they categorize. This is from Emory, and it's a very nice illustration of how you should treat these patients. Again, this is not a guideline, but it's a suggestion that people are divided into 3 levels. Level 1 is patients who don't have thrombosis, but their D-dimer and their D-dimer is less than 3,000. And level 2 is patients with elevated D-dimer more than 3,000, again, no thrombosis. And then level 3 is the highest risk with known or suspected thrombosis, or patients who are in the vent, you can't get them off the vent, they're very sick, multi-organ failure. And the recommendations really quickly is for level 1, you're treating them with a low molecular weight heparin, 0.5 milligrams per kilogram per day, and you adjust renal function, or you can use unfractionated heparin if they have severe renal insufficiency. For level 2, you increase the dose to 1 milligram per kilogram, and for level 3, you're giving 1 milligram per kilogram every 12 hours, or a heparin drip for a severe renal insufficiency or changing renal function. The anti-10A measurements or goals are also different. They go higher as the risk of the patient goes higher. And what's interesting is they also discharge patients home on oral anticoagulants, mostly rivaroxaban or apixaban, depending on the renal function. So the thinking now is this is a hypercoagulable state that is going to continue for the next 3 months. So they're really suggesting that you should treat them for 90 days with anticoagulation. I'll stop here, and we'll take questions at the end.
شكرا جزيلا دكتور خضر عثمان والدكتور أحمد الكجم على البرزنتيشن الممتاز جدا جدا. حنمشي لدكتور خضر دلوك، حيقدم لنا برزنتيشن عن علاقة الإلكتروفيسيولوجي والكوفيد 19. خاصة حنتكلم عن موضوع الQT prolongation وعلاقة الميديكيشنز اللي بياخدوها المرضى اللي عندهم مشاكل أريثميا مع الميديكيشنز اللي هي مقترحة كأدوية محتملة للكوفيد 19. تفضل يا دكتور خضر.
شكرا محمود، وشكرا دكتور أحمد الكجم ودكتور خضر عثمان. My talk, as Mahmoud has said, we will share some of the thoughts we have about arrhythmia in COVID-19, as well as some of the concerns of QT prolongation with the different drugs that are going to be used or will be used with COVID-19 and some of the cardiac medications. Preliminary data that came from Wuhan, China, early between January and February, reported a rate of 16.7% of arrhythmias in patients with mild and moderate COVID who were treated on the floors or the general wards. Up to 44% of patients who were treated in ICU with severe COVID developed arrhythmias. The type of these arrhythmias, unfortunately, that were encountered were not specified. And there are limited reports on what these types of arrhythmias and what type of medications they were treated with. In the EP community, we anticipated during the COVID pandemic, a lot of these arrhythmias will be atrial arrhythmias and specific atrial fibrillation, since it's the most common arrhythmia that we encounter in clinical practice and we encounter in the ICU setting. Having said that, malignant ventricular arrhythmias may develop as well due to increased catecholamine surge, especially in patients who are treated in ICU, who are on pressors and who are on inotropes. As Ahmed Kajam has mentioned, there are reports of acute myocarditis, sometimes even presenting with sustained ventricular arrhythmias. We also anticipated that we would see an increase or a surge in ICD shocks in patients who have implantable cardiac defibrillators. But having said that, so far we have not seen that surge, in ventricular arrhythmias and ICD shocks. In this single-centered retrospective study that came from Wuhan, China, this is from Union Hospital, they looked at the outcomes of their in-hospital cardiac arrest. Out of 760, COVID positive patients, they had 151 patients who developed in-hospital cardiac arrest. That is to say a mortality of 20%. Their data was complete for 136 patients that they analyzed, and the initial presenting rhythm in those cases was predominantly asystole and PEA. Up to 90% of in-hospital cardiac arrest, the presenting rhythm was asystole. In about 4.5% it was PEA, and only in 6% the presenting rhythm was VF and VT. The chief of cardiology in my institution heads the National Surveillance Center for Remote Monitoring of Devices across the entire VA system. And so far, we have not seen any surge in ICD shocks or ventricular arrhythmias. This is a nice schematic that was published in JAMA that represents virus-induced host immune system response with the production of cytokines, interleukin-6, and as well as the viral processing within the target cells that has been elegantly pointed out by Dr. Khidir Usman. These viral life cycle steps provide potential targets for drug therapy. During the pandemic, finding therapeutics, of course, is very crucial. It is proposed to do so by repurposing existing drugs like chloroquine and hydrochloroquine, as an example. The global pandemic has put an enormous pressure on clinicians and on the FDA to act swiftly to make medications available. When very limited observational and anecdotal evidence rose about possibility of hydrochloroquine and chloroquine as potential targets, the FDA issued an emergency use authorization, what is known as EUA, on March 28th, allowing for chloroquine and hydrochloroquine to be used to treat COVID-19. Other medications as well have been used all around the world to try to see if they can work for COVID-19. As you can see, chloroquine and hydrochloroquine, they block the viral entry into the cell by different mechanisms. I'm going to concentrate on those, not because they're effective. So far, we do not have any evidence to support chloroquine or hydrochloroquine or any other medication that is shown up on this schematic. But I'm going to concentrate on chloroquine, hydrochloroquine, azithromycin, because these are the available medications in different institutions in different countries. And as well, I will highlight remdesivir, which is an antiviral medication which have promising results. And the ID colleagues have a lot of enthusiasm about it in COVID-19. A major concern with the concomitant use of some of those COVID-19 directed treatments and some of the cardiac meds, especially antiarrhythmics, is the synergistic effect on the QT interval prolongation. When the QT interval prolongs, patients can potentially develop drug-induced ventricular arrhythmias, what we know as torsade du poing. As you can see on the lower part of this slide, it shows the action potential of a Purkinje cell or a ventricular fiber, showing phase 0, which is the depolarization phase, followed by phase 1 and 3, which represents the repolarization phase of that cell. IKR and IKS in phase 3 are predominantly the channels that get blocked with several antiarrhythmics, as well as chloroquine and hydroxychloroquine, and some of the antiviral therapies as well. And hence that will be represented on the ECG by a prolongation of the QT interval. The ECG in general and the QT are a summation of all those cells together and their action potential. And the repolarization phase is depicted on the ECG by the QT interval. It's one of the main measurements that we look at because it has been shown to be a predictor of sudden cardiac death and the risk of drug-induced torsade du poing. On the right side of the screen, you can see that traditionally lead 2 is used for measuring the QT interval because the T wave vector is in alignment with lead 2. And hence, the T wave will be a discrete single T wave in comparison to other leads in which you might see a T and a U wave. Alternative leads are lead AVR and AVF. As you see, they're in close proximity to the T wave vector, similar to lead 2. And in the right bottom, you can see that the QT interval is measured from the initial portion of the Q till the terminal portion of the T wave as depicted on this image. The pro-arrhythmic risk of these combination of drugs, the COVID, some of the COVID-19 drugs and some of the antiarrhythmic drug is not really known. But we know that the increased risk of torsade de pointes occurs whenever the QT prolongs, more so if it's more than 500 milliseconds, and whenever the drug increases the QT interval by more than 60 or 70 milliseconds, especially if this happens rapidly. The incidence of torsade de pointes increases with increasing the QT interval, and incrementally, it can exceed 10% increased risk of torsade de pointes if the QT interval is greater than 550 milliseconds. Having said that, there is no threshold of QTC prolongation at which drug-induced torsade de pointes is certain to happen. There is a lot of different factors that come into play. There are patient factors, there are drug factors, and sometimes there are scenario or clinical factors that come into play. This is a very good resource, the crediblemeds.org. In 1999, because of the increased concern for the potential scope of drug-induced torsade de pointes, the Georgetown University Center for Education and Research on Therapeutics was awarded a federal grant to evaluate the available evidence to assess drugs for their relative risk to cause torsade de pointes. The center ended up moving to Arizona in 2012, but this is an FDA grant supported center in which all of the QT prolonging medications are available. Drugs are categorized into 4 groups: those who have confirmed risk of torsade de pointes, those who have a potential risk of torsade de pointes, those who have a conditional risk for causing torsade de pointes, and then there are those list of medications that should be avoided in congenital long QT syndrome. This slide shows a table from the Liverpool Drug Interaction Group that have been available since the COVID outbreak. It shows the different COVID-19 drug therapies on the columns, and on the left side you can see the different antiarrhythmic drug medications and their potential drug interaction. Those boxes in red indicate that those drugs should not be used together. As you can see, amiodarone is not recommended to be used or even contraindicated to use with chloroquine and hydrochloroquine, according to the Liverpool group. Similarly, flecainide is another red box. There is a discrepancy about dofetilide. If you plug the same medications in Micromedics or Hippocrates, you can see that actually dofetilide is a red box. And on the other side, mixilotine, which is highlighted in red with chloroquine and hydrochloroquine, they're actually of moderate or low severity if you plug them in Micromedics and Hippocrates. Lidocaine is very safe to use with the different COVID-19 medications. Unfortunately, the only antiarrhythmic drug which is available is amiodarone. The only options for COVID-19 drug therapies that are available in Sudan are chloroquine, hydrochloroquine, and possibly erythromycin, although the data for erythromycin is very low and it's not recommended to use the combination. But as you can see, there is severe risk of drug interactions if we use amio with chloroquine and hydrochloroquine. This is an important slide as well, highlighting that a lot of our cardiac drugs, including antiarrhythmics, are substrates of cytochrome P50. As you can see, amiodarone, dofetilide, quinidine, dronidone, sotalol are all substrates of CYP3A4. On the first column, you can see that azithromycin as well as chloroquine, which is not mentioned in this table, are inhibitors of CYP3A4. What that will do is it will increase the levels of amiodarone and all antiarrhythmic drugs that are substrates for CYP3A4, potentiating their effect on prolonging the QT interval. On the right side, you can see that beta blockers, mixilotine, lidocaine, and flecainide, these are CYP2D6 substrates, and chloroquine is another drug that can inhibit CYP2D6, and it will increase the level of beta blockers, mixilotine, lidocaine, and flecainide. And hence, you might notice that if you use chloroquine in your patients, that their heart rate might be slower, and there is more tendency for cardiac toxicity with lidocaine and mixilotine. To help identify those subsets of individuals, this is a risk score to predict the QT interval prolongation in hospitalized patients. With the pandemic, a lot of hospitals, especially in New York, China, and Italy, there is a lot of demand for telemetry units, which is what we use to monitor and mitigate the effect of the prolongation in the QT interval causing drug-induced torsade. So this is a risk score that can help, stratify those individuals who, by the virtue of underlying genetic predisposition, by the virtue of multiple modifiable and non-modifiable factors, these patients can prolong the QT interval significantly. And the cutoff is 500 milliseconds for those who can prolong the QT significantly, as well as those who can have an exaggerated QT interval prolongation of a delta of 60 milliseconds. Patients can be categorized into low, moderate, and high groups based on this. The incidence of QTc prolongation to a significant level, that is to say more than 500 milliseconds, or with a delta of 60 milliseconds, is 15% if you score low in this scoring system. It is 37% if you're in the moderate group, and it's up to 73% if you score in the high group. So I think this is a good tool to use if you need to triage your tele units in the hospital. A few words about chloroquine and hydrochloroquine. As I said, there is no proof so far that hydrochloroquine or chloroquine are effective in treating COVID-19. So this is an important message to know. But there is moderate in vitro activity of chloroquine and hydrochloroquine that has been seen in the SARS-CoV-2 virus. There is very limited observation and anecdotal data to suggest that there is some activity of the COVID against the COVID virus. And but these results are inconclusive, and there are several limitations to the studies that have been reported. It is important to know, as I said, both chloroquine, hydrochloroquine, they prolong the QT interval by blocking the IKR channel, which is the hERG channel. Important as well to know is that chloroquine and hydrochloroquine, they are inhibitors of the cytochrome P3A4, as we mentioned, as well as CYP2D6. And this will potentiate the effect on all or most of our antiarrhythmic medications, which are substrates of those cytochromes. Of note and interest is that chloroquine has electrophysiological properties. There is limiting data suggesting the effectiveness of chloroquine and hydrochloroquine in atrial fibrillation and suppressing ectopy. One, of course, have to weigh the benefit and the risk of using hydrochloroquine and the risk of prolonging the QT interval. In our institution, hydrochloroquine is available. It's mainly indicated for people with O2 sats less than 90% or requiring oxygen. In patients who have moderate to mild to moderate COVID, plus or minus 2 risk factors, which include age above 65, cardiac diseases like CAD, heart failure, and arrhythmias, COPD, diabetes, and immunosuppression. Our criteria is, to start chloroquine, provided that the QT interval is less than 490. Once we start chloroquine, at least in the few cases that we have in our hospital, if the QT interval prolongs by more than 50 milliseconds, we tend to stop, any offending medications. We replete the lights, potassium, and magnesium. We monitor the patient very closely on tele and by daily ECG. A few words on azithromycin. Azithromycin, as you know, is a macrolide antibiotic that has been created in the 1980s as a natural antibiotic, form of erythromycin. It has been shown in one study, the French study, that used the combination of hydroxychloroquine and azithromycin, that 6 of their patients had less viral shedding. We know from in vitro studies that azithromycin have antiviral and anti-inflammatory properties. These have been mainly in Zika virus, as well as rhinovirus, and I think as well in Ebola. But we don't have any strong data on the effect of azithromycin on the SARS-CoV-2 virus. In 2013, the FDA put out a statement because there was increased reporting of QT prolongation and torsade de pointes with azithromycin. We do not know the mechanism exactly of how azithromycin prolongs the QT interval. In vitro studies have shown that it blocks sodium channels. It slows down the heart rate, causes bradycardia. It prolongs the PR interval, prolongs the QRS interval. In animal studies on high doses, azithromycin was found to block the IKR channel as well. But overall, so far, we don't know the exact mechanism of how azithromycin prolongs the QT interval. It is important as well to know that azithromycin is not a substrate of CYP3A4, but it is an inhibitor, and hence it can potentiate the effects of amio and all other antiarrhythmic medications. This is a case report in which azithromycin was used in combination with amiodarone. And as you can see on the right side, the QT prolonged to more than 600 milliseconds, requiring azithromycin to be stopped during this case report. Some data is starting to emerge from New York. This is a retrospective study from NYU, Langone Medical Center in New York. They looked into the QT interval in patients with confirmed COVID-19 who were treated in their institution with a combination therapy actually of hydrochloroquine and azithromycin. They looked at 84 consecutive patients. And as you can see, in those 84, 7% were actually on amiodarone. So they were on hydrochloroquine, azithromycin, and amiodarone. You can see on the left side that the QT interval started to prolong on day 3 of therapy and continued to do so in day 4 and 5. On the right side, you can see that 11% of patients developed significant QTC prolongation as defined by a QTC interval of more than 500 milliseconds. In multivariate logistic regression analysis, they found that acute renal failure predicted the risk of developing significant QT interval. Your baseline creatinine and amiodarone therapy had a trend as well, but they did not meet statistical significance. In all their cases, in all the 84 cases, there was no reported drug-induced torsade du poids. The Heart Rhythm Society task force during the COVID-19 put out the statement saying that it should also be noted that reported experiences in China and recent experiences in the US at different centers caring for COVID-19 patients have not reported a high risk of torsade du poids or QT prolongation. I think, you know, despite that we have not seen a lot of torsade du poids or drug-induced torsade du poids, it's very important to be vigilant and to monitor the QT interval in your hospital and your settings. We have to weigh the benefit of using these drugs that so far have not been proved to be effective on COVID-19, with the potential risk of causing QT prolongation and causing torsade du poids. It's always a game of benefit and risk, and how benefit much you will get from a drug compared to the other. I will have a few words on remdesivir because it's a promising drug. Remdesivir, you know, inhibits RNA-dependent RNA polymerase. It is not a significant inducer of or inhibitor of the CYP enzymes. It has been noted, you know, in vitro studies that it has strong in vitro activity against the SARS-CoV virus. The first clinical use of remdesivir was in the treatment of Ebola, and that's why we are seeing it now, you know, as a repurposed drug for COVID-19. There is no major drug interaction between remdesivir that we know of with all the antiarrhythmics, as you already saw on the Liverpool interactive group table. Different hospitals have different algorithms. You know, there are algorithms that have been put on by the Mayo Clinic. This is a proposed algorithm in our hospital. This is an example of an algorithm for VT if a patient comes with ventricular arrhythmia ending up in the ICU. We usually measure, of course, the QT interval from baseline ECGs from prior. We check their electrolytes, mainly potassium and magnesium. We avoid all unnecessary QT prolonging medication. Depending on your institution, of course, and what COVID-19 therapies are available. If you have remdesivir available in your institution, it will be safe to initiate amiodarone therapy. In other institutions in which remdesivir is not available, and chloroquine and hydrochloroquine will be used, plus or minus azithromycin, there is moderate or severe risk of you know, prolongation of the QT interval with the combined use, and hence lidocaine would be the first choice to use in these cases. Unfortunately, in Sudan, the only antiarrhythmic that is available is amiodarone, and chloroquine is the only drug that can potentially be used in Sudan. So I think in Sudan, people have to be very vigilant. If it's available, it will be recommended to get a baseline QT interval before initiating chloroquine. Even in patients who do not go into arrhythmias, I think it will be good to get a baseline ECG, or on ICUs or teleunits. It's important to get you know, intervals from the teleunits. I think it's important after this COVID-19 outbreak is over that the message goes to the Federal Ministry of Health, Dr. Akram, to pay a lot of attention to different drugs, cardiac drugs, which are life-saving, and there's streptomycin, there is streptokinase. There are different antiarrhythmics, you know, Lasix, and all other different medications which are not available, and they have to be available, readily available for أطباء القلب في السودان. This is a table that shows the drug interaction between the different COVID-directed treatments and antiplatelets and antithrombotics as well as streptokinase. I just want to highlight here, since streptokinase is the main thrombolytic which is available in Sudan, that it does not have any drug interactions with the different COVID treatments, including chloroquine. So just to summarize, in terms of the arrhythmia protocol or summary, every patient should be evaluated in an individual level. The management should be guided by your institution, what drugs are available in terms of COVID-19, in terms of cardiac and antiarrhythmic drugs. You have to prioritize telemetry units for COVID-19 patients, in which hydrochloroquine, chloroquine plus or minus azithromycin will be used. You can guide this as well by the risk stratification tool that I have showed you earlier on. Very important to remove all unnecessary QT prolonging medications, those that we regularly use for as an antiemetic, including Zofran. A whole list of those medications can be found in crediblemeds.org as well as in Hippocrates. Very important to check your electrolytes on a daily basis and to replete potassium and magnesium to above 4 and 2 respectively. A multidisciplinary team plan, including your ICU, intensivist, infectious disease docs, as well as your cardiology team, I think will be important. And don't forget anticoagulation, as highlighted by Dr. Ahmed Kajam earlier on. One word about heart failure. We have not seen a surge in heart failure admissions, at least in my institution and talking to different people around the country. It is, of course, known that people with acute myocardial injury secondary to myocarditis can present as acute onset heart failure. But overall, we have not seen an enormous surge in heart failure. Whether this is because people are staying home and eating healthy and very compliant in taking their meds, that could be one reason. And I think patients are very good in staying home and taking their meds. يعني رسالة للسودانيين، يعني المرضى هنا في الوست يعني بيسمعوا الكلام and they follow the recommendations very religiously. نتمنى انه الناس في السودان يعني تهتم بانه تقعد في البيوت ويعني ياخذوا الادويه بتاعتهم في وقتها عشان ما يضطروا يمشوا للمستشفى و to be exposed يعني لمرضى قد يكون عندهم الكوفيد 19. The last couple of slides are about ACE inhibitors and ARBs. There was a lot of concern whether people who are on those antihypertensive medications, whether they're at a high risk of getting COVID or having severe forms of COVID-19. معظم الstudies that have been shown by Dr. Khidir Uthman or Dr. Ahmed Kajam have shown that a lot of comorbidities, mainly hypertension, was seen in those COVID-19 patients from China, from Europe, and from the US. A lot of those are on ACE inhibitors. There is two schools of thought. One group thinks that because the virus gets into the host cells or into the body through the ACE2 receptors, if you are on an ACE inhibitor or on an ARB, this will increase the expression of this ACE2 receptor, and hence you will be exposed more to the virus. There is another group that actually think that the use of ACE inhibitors and ARBs, as you can see in this schematic, they prevent the production of angiotensin II, which can actually promote lung injury, can cause adverse myocardial remodeling and vasoconstriction and other vascular deleterious effects in our system. So there's two schools of thought. So far, there is no proof to either theories. If you go to the next slide, Mahmoud, you can see that all the cardiovascular bodies in the US and in Europe have put out a statement that for patients who are on those medications to continue using them and not to stop. Of course, patients who are admitted in ICUs with septic shocks because of COVID-19, in all cases, we would have to hold all antiarrhythmic, all antihypertensive medicines if people are hypotensive. So if you are on those medications, ACE inhibitors, ARBs, there is no data to suggest that taking those medications, you are at an increased risk of having COVID-19. I think with this, I come to the end of my talk. These are two of the cardiac plants that we see in cardiology. The one on the left is the Syncona plant from which quinine and quinidine have been developed. The one in the middle is the digitalis flower from which digoxin comes out. These plants have been known for the last 100 years. The one on the right هي شجرة الصنط اللي بيطلع منها القرض. أتمنى يعني one day we will see that our observations that we see in daily life في السودان get translated into science. Instead of being at the back seat, يعني معظم الأوقات إحنا we receive science and we receive knowledge from the West. I hope one day we can move on and be leaders and translate our observations into science and data. With this, I will give the microphone to زميلي مصطفى حسن to tell you about structuring the cardiovascular system in the middle of the COVID-19 outbreak. Thank you.
ايوه شكرا جزيلا. حننتقل زي ما دكتور خضر قال. شكرا دكتور خضر على البرزنتيشن الجميل جدا. حننتقل لدكتور مصطفى. قبل كده عايز اذكركم ان احنا حنجاوب على الاسئله في نهايه المحاضره، فممكن تكتبوا اسئلتكم في الكومنتس وممكن تشاركوا المحاضره دي اذا حسيتوا انه المحتوى بتاعها هيفيد اطباء او صيادله او اي ناس عاملين في الحقل الصحي، ممكن تشاركوها معاهم عشان الفائده تعم. دكتور مصطفى حتتفضل، انا حافتح البرزنتيشن.
Bismillah ar-Rahman ar-Rahim. Shukran ya Mahmoud. Thank you to my colleagues. Very comprehensive review of the so far known literature in this area. We know, as we've seen, there's not a lot of proven facts, but this is an evolving field. This is a new pandemic that has affected the whole world. I've been tasked with talking about restructuring the cardiac services, which I think is very, very important. I think one important fact about this pandemic is the nature of the virus and the contagious nature of this virus. This virus can spread very, very quickly. Plus, it's a very deadly virus, so it can kill people, but it can also spread in a very fast fashion across the world. As we've seen throughout the past few months. So it's the interaction between the virus and the health services is very critical, because obviously when people get sick, they go to the hospital and they have to get treatment for, which could be a very prolonged and labor-intensive treatment. Given how contagious this virus is, I think most of you guys have seen this slide before in previous presentations. It shows the spread of the virus and the onset of cases, and you can see that's represented by the dotted bell-shaped curve. The straight white line, dotted line, is the health services, the capacity for the health services to handle this epidemic. So you can see if you have a surge of cases with a very rapid spread, that you can easily overwhelm the health services, and you may not be able to take care of patients. Well, I'd like to think of our beloved country, Sudan, and this line, this white line, could be much lower than where it is now on this slide. It could be much, much lower. So the health services can easily be overwhelmed by the spread of the virus. So again, highlights the importance of listening to the authorities and abiding by the social mitigation strategies that have been adopted worldwide. I think this slide has proven very true for particularly two countries in Europe, Italy and Spain, and they easily overwhelmed their health services, and that's why a lot of people died and their mortality rate was very high. Social medication strategies are the hallmark. This is the only strategies, only treatment that have been shown to be effective so far. Yani كل medical therapy, the medications, is all a speculation. I think so. Social medication is the only thing that has been shown to slow and curb the spread of this virus. So it's very important that if you don't have COVID-19, that you don't get the virus by following the mitigation strategies that have been advised, which is washing your hands frequently, avoid contact with any sick people. If you don't touch your face, don't touch your mouth or your eyes with your unwashed hands, and don't eat any raw food. Thoroughly cook any meat and eggs if you're going to eat that, and avoid contact with animals and animal products. If you're get infected with the virus or have any symptoms suspicious for acquiring the virus, stay at home. Just avoid contact with any other people, because obviously that way you can transmit the virus to them. Also cover your nose, your mouth. If you're coughing or sneezing, make sure you do that on your elbow or on a tissue. Keep objects and surfaces that you touch clean, and wear a surgical mask when you go outside or you come in close contact with other people. So this, again, highlighting the importance of this. This is the only way that the countries that have been successful so far in curbing the spread of the virus have done it through these social distancing or social mitigation strategies. So and as a segue to talking about the restructure of the cardiac services, I think it's very critical to think of the cardiac services as the place where sick people are going to go. So if you overwhelm these services, the hospital beds, ICU beds, you may not be able to take care of these people. Then you may have to ration things. So as a precaution, I think most hospitals, clinics, big healthcare systems, as well as the big policymakers, had to take measures to restructure their services, including the cardiac services. So, and the two goals for doing that is obviously to preserve resources. So you have limited resources, and if most of these resources are going to go to taking care of COVID-19 patients, you're going to need a lot of PPEs. You need staff as well, so you have to protect your staff. Your staff is a valuable resource. So it's very critical that you restructure this, and ration these services so that you can take care of the expected surge in cases that may come your way. This is a diagram that was published by the CDC as to how to put on and take off personal protective equipment. Very important that you do it in the correct way. So the personal protective equipment are gowns, some masks or respirators, goggles or face shields, as well as gloves. So you have to follow the diagram and put it correctly so that you don't contaminate yourself or contaminate other areas in the hospital. I divided my presentation into we typically function as cardiologists in two worlds, the outpatient world and the inpatient world. So the outpatient world, typically, it's cold cases, it's elective cases, or patients that may need some cardiac evaluation in a clinic setting, and also outpatient testing for these people who tend to be somewhat stable, as well as outpatient procedures that we can do. So I think all these, given the cold nature of these services, most of them can be canceled or changed to a very low volume. I think to preserve your resources and preserve your time as well as a cardiologist, to be present for taking care of patients in the hospital, you have to cut back on the outpatient cardiac services. You have to educate and protect your staff in clinic, make sure they understand the consequences of being in a clinical area at the time of this epidemic. All elective cases should be canceled. I think most hospitals have put some guidelines as to what defines elective cases. I think in our institution, they defined it as that a case can be postponed for 30 days without any clinical consequences to that patient. So that patient can wait for 30 days without having to suffer any consequences. So it's sort of a murky area, but I think you can use common sense, and I think most people can do that very successfully. Most of the clinics, I have implemented this in my private practice, as we've changed to telemedicine visits. So most of the patients are seen through a telephone and a video conference kind of technology. So you can see the patients, you can talk to them, you can address their issues for the most part through a telemedicine encounter. I think even the Ikhwan of Sudan, I think this I've seen some of the cardiologists offer their phone numbers for WhatsApp contact with the patients, and I really admire that from them. I think telemedicine doesn't have to be a very sophisticated software. It can be done through any simple mean. So I think that can be done for most of the countries. So most of the non-urgent tests can also be canceled. Echoes, stresses, Holters, all of these things. The patient has severe symptoms. You try and mitigate that through having staff available over the telephone to advise patients, and so patients can call, can get refills on their medications. They can get advice as to if they have symptoms about how to do about these things. So I think most of the outpatient, in general, outpatient cardiac services can be postponed or cut back significantly to preserve resources for dealing with this epidemic. The inpatient services also can be structured in an effective way to deal with this pandemic. And I divide this into 5 areas of inpatient cardiac services: the inpatient consultation, the STEMI protocols and cath lab. Inpatient cardiac procedures can also be restructured. So the inpatient consultation, I think you can designate, that's what most hospitals have done, designate a dedicated COVID-19 consult team so that not a lot of people get exposed to these patients. So if there's one team that handles the consult for these patients, so you've got one attending, maybe one fellow or resident that can go and see these patients, and so that you've limited the exposure to the staff. You also limit non-essential staff such as medical students. I don't think they need to be there for this. Use telemedicine. Some hospitals have access to telemedicine where the camera will be inside the room. You can see the patient remotely without entering the room. If that's possible, it can be used. Also, limit testing. If you can avoid exposing other staff, such as echo technicians, EKG technicians, vascular techs, if anything can be deferred, or non-urgent test, I think would be better to defer that. Most hospitals have also, as my colleague Ahmed Al-Kadhim alluded to earlier, the STEMI protocols have been changed in most hospitals to try and use thrombolytic therapy as much as you can, and avoid taking the patients with acute STEMI to the cardiac catheterization laboratory to avoid exposure to the staff and other and contaminate the lab area. If you can, now our hospital, for example, we've dedicated one lab as a COVID-19 lab. It's with a negative pressure. We use a negative pressure room. Use a room that may be separated from the others. You can use as a dedicated lab for suspected or confirmed cases of COVID-19, and also limit the non-essential staff. So if you can do the case with less number of technologists and nurses, just keep that to the minimum. The ACLS protocols in the hospital have also changed. I think the American Heart Association has published updated guidelines as to how to do an ACLS protocol in a patient with suspected or confirmed COVID-19. I have a separate slide on that we'll address next. There's also some protocols that have been devised in our hospital as to how to handle reusable equipment, such as the echo machine, your echo probe, your EKG machine, and stuff like that. So these have to be cleaned thoroughly, make sure, particularly if they're being used on a patient who's COVID positive. Inpatient cardiac procedures, also try and minimize those to the minimum unless something is needed emergently or urgently. Some thoughts about the cath lab. Every patient should be considered infected until proven otherwise. So whenever you take a patient to the cath lab, always make a thorough screening for those patients with making sure you understand their risk factors, if they had any symptoms, or if they came in contact with any suspected or confirmed patient of COVID-19. Also designate a COVID cath lab, as we mentioned earlier. This has to be a negative pressure room, separate lab from the common hallways, sort of tucked away lab that you can take patients in and out without having to contaminate the whole hospital area. Keep the COVID lab as empty as possible, so just use it particularly for those kinds of patients. And keep all needed equipment inside the lab so that staff don't have to go run in and out and have to change PPEs and stuff like that. Also, if you have to intubate a patient, try and do that outside the lab, because as you know, intubation carries the highest risk of aerosol dispersion in the air and the highest risk of contamination. So if a patient is impending or having respiratory difficulty and you have to take him to the cath lab, make sure you intubate him in an area in the ER or somewhere where you outside the lab. Labs have to be terminally cleaned after a COVID positive case. And all cath lab patients should wear a surgical mask. So put those masks on the patient. That will result in less risk to your staff. And also train your staff on how to appropriately use PPEs, as we mentioned earlier. It's very, very important. People can easily, particularly in the setting of an emergency, people can forget the steps, how to wear the PPE, how to put on the PPEs and how to take them off. So train the staff and train them multiple times so that they, even in the setting of an emergency, they don't forget to use it properly. The American Society of Echo has issued some guidelines on how to order, echo studies and how to navigate the decision making. And as a simple, without going into this complicated tree algorithm, I would say that if you can do without the information you will get from an echo, do. So don't order an echo. If that patient does not need an echo and you don't need that information for clinical decision making, just don't order one. But if you have to, then make sure you understand the status of the patient, whether the patient is COVID confirmed or COVID suspected. Make sure your staff is adequately protected, particularly with TEE procedures. Obviously, any intubation procedures carries the highest risk of airborne dissemination of the virus. So make sure the staff is aware of the status of the patient before they go in. Make sure they have the protected gear when they go in to avoid risk to the staff. And this is the updated ACLS protocol that the AHA has published recently in response to the COVID-19 epidemic. So the and it's the algorithms are pretty complex and very lengthy, but I've summarized this in two main changes that they recommended. First of all, you have to understand that about 3 to 9% of all COVID positive patients will become critically ill, and they may develop cardiac arrest in the hospital. A second important piece of information is that most of these cardiac arrests are not rhythmic cardiac arrest. They are respiratory events. So that's, I think, very important. So they really emphasize 2 main items, which is reduce exposure to the rescuers who are involved in the ACLS team. And that's very, very important. The second aspect is prioritize oxygenation and ventilation strategies, and make sure in doing that, you also pay attention to the staff. So proper PPEs should be worn by all people who are going to be called into a code in the hospital. Limit the personnel to only those essential to performing the ACLS protocol. Use mechanical CPR devices such as Lucas devices. I think they can be very, very useful. Instead of having 4 people who perform CPR and alternate, you have the device and it will do the job for you. Also, make sure that you clearly communicate the COVID-19 status to the team. Anybody who comes in as the code blue is being called and the staff is running into the room, make sure that's communicated clearly to the staff so that they can get protected before they enter the room. And then the other aspect is prioritize oxygenation and ventilation strategies. There are these high filters that high particulate filters that can be attached to mechanical ventilation devices. So that's very important. It will seal the circuit after the patient is intubated, so that aerosols and the droplets cannot leak from the patient. So it does reduce the contamination. After healthcare providers assess the rhythm and defibrillate, which obviously is the priority in all ACLS protocols, then you're going to pay attention to the ventilation and the intubation. Minimize the likelihood of failed intubation. For example, if you have used the most experienced anesthesiologist who's on the field or as part of the team, the most experienced one, so that you can have a one try and it's successful. You also use, they recommend using video laryngoscopy for getting the tube in the right place on the first shot, so that you can avoid multiple trials and multiple exposures. They also recommend that people address the code status and some other things that are pertinent to practices here in the West, and establish institutional protocols for how to address these things before, as the patient is getting sicker and sicker, before they go into a code. This is the protocol. I'm not going to go into, it's a very busy slide, obviously, but I'm going to have that on the slide as a reference for people to refer to. But I pretty much summarized all the changes that they recommended on the previous slide. So this is the BLS protocol, and the next slide is going to have the ACLS protocol. But I think the key aspect is to protect the staff, protection, so that people don't get exposed. The last slide here has these strategies for people to deal with the economic impact of this. This is pertinent to people in the U.S. So if anybody has any question about these things, they can email me or contact me separately. Shukran jazeelan.
شكرا جزيلا يا دكتور مصطفى. الآن نحن بعد ما أكملنا البرزنتيشن حنمشي للأسئلة، وأنا حشوف الأسئلة الجات من المتابعين. برضو إذا الناس عندها أسئلة ممكن تواصل تسأل، حنحاول نخصص زي 10 ل 15 دقيقة للإجابة على أسئلتكم. طيب أنا عندي طيب السؤال لدكتور خضر ودكتور مصطفى. في سؤال من خالد، دكتور خالد دوسة بيسأل عن إنه هو بيقول إنه both amiodarone and hydroxychloroquine have long elimination half-life, like around month. The question is, when do you think we can see resolution of drug-induced QT prolongation? اتفضل يا دكتور مصطفى.
افتكر if somebody's already Khalid alludes to people who are already on amiodarone, and amiodarone طبعا has a very long half-life. If the interaction is between طبعا chloroquine and azithromycin have shorter half-life, so I don't know the specific answer, but my response would be even if you stop the amiodarone and somebody who's been chronically on it, they may still have that QT prolongation. But if you eliminate the other drugs which have shorter half-life, that might help you if you start seeing increased QT interval on these patients. So I would recommend. By the way, I think most people are trying to stay away. And if somebody's coming into the hospital and they have some arrhythmia issues and you have to use an antiarrhythmic drug, I would shy away from using amiodarone for the reason for the potential interaction. I would rather use perhaps lidocaine or some other antiarrhythmic drugs that have less potential for QT prolongation. Khidir, لو عندك أي comment.
شكرا يا مصطفى وشكرا خالد دوسة. It's a good question. طبعا كلوروكوين الهاف لايف بتاعته elimination half life is almost 100 days. Amiodarone almost 6 months. We don't know the answer. This is the short answer. We're in a dilemma. A lot of our patients are on amiodarone. They're on dofetilide. They're on flecainide. They're on a lot of antiarrhythmic medications to treat atrial fibrillation and ventricular arrhythmias. And we really don't know what are we going to do if a patient comes in who are on those medications and they develop COVID. What are we going to do? Are we going to stop dofetilide? As you know, dofetilide and sotalol are medications that we initiate in the hospital for 3 days, specifically because they can prolong the QT interval and they're high risk for causing drug-induced torsade du pointes. We don't know the answer. I think as long, if you are going to use amio and chloroquine, once the chloroquine course is done, which is 5 days, once you see a trend down on your QT interval, I think this is something that will indicate it's unlikely for it to continue to prolong. Maybe one option is to repeat an EKG in a week and in 2 weeks, just to convince yourself that the QT is at least not prolonging, it's staying steady, if not trending down. Thank you.
شكرا جزيلا. طيب عندنا سؤال ثاني من مها أزهري. حوجه السؤال ده لدكتور خضر عثمان. هي بتسأل is there any rule for steroid to decrease the severity and improve the prognosis of myopericarditis? يعني هي I think she means specifically in COVID-19 myopericarditis.
Thank you. This is a very good question, actually. We use steroids in the non-COVID patient. Steroids in COVID, actually, the data is not conclusive yet. In fact, there are some people who are using it for mild to moderate disease. So if the patient otherwise is okay, I think you could use a short course of steroids, provided that is not interfere with other conditions. But there are no data to confirm the use of steroids.
اوكي طيب شكرا جزيلا. اتفضل يا دكتور اكرم. احمد لو عندك اي اضافه.
لكلام الدكتور خضر اتفق معه 100%. تقريبا السوسايتي الوحيده قبل اسبوع او اقل من كده اليوروبيان سوسايتي اوف كارديولوجي actually approved the use of corticosteroids, but only in very selected patients with refractory shock in COVID-19 patients. Like they made the disclaimer that this is based on weak evidence. So, if you're desperate, the patient is not doing well, you can, and you really suspected myocarditis, you can use the corticosteroids. But I'll be very, very careful about it.
اوكي، شكرا جزيلا. طيب السؤال اللي بعده لك برضو يا دكتور احمد. ابو الزين بيسال what is the prognosis for people with with elevated cardiac biomarkers?
So elevated biomarkers, when we look at COVID-19 patients, actually we sum everything in one category, which is cardiac injury. So just like what Dr. Uthman illustrated in his presentation, there are multiple causes for myocardial or cardiac injury in COVID-19 patients. Patients from China and from other places who had COVID-19 and they were critically ill in the intensive care unit, patients who showed evidence of myocardial injury or cardiac injury had 50% mortality rate. So anybody with elevated troponin is at a high risk for adverse outcomes.
طيب ممتاز. في سؤال عن ليك يا دكتور خضر دلوك. I think ده هيكون آخر سؤال لنا. علا بتسأل من إذا كان في if there has been any significant decrease in the number of cardiac related admissions during the past period of COVID-19 spread.
والله overall admissions I would say less. لأنه a lot of people were giving the recommendations to them to stay home. We are actually very active in telemedicine and video conferencing with all our patients. Especially cardiac patients. We try to reassure them by phone calls, by video conferencing. If we need to adjust medications over the phone, we do that so that we can keep them out of the hospital as much as we can. So at least I can speak on my overall to my institution that overall cardiac admissions have been less. We haven't seen a surge on admissions. Thank you.
طيب انا هفتح الفرصه لكم كلكم لو كل واحد عنده اي اضافه او كلمه اخيره قبل ما نختم.
بس انا عايز اشكر سابا again. This is I think a very tremendously important platform الناس to exchange ideas experiences. I think these lives have been amazing. I watch most of the lives myself. I've learned a lot. I think it's an incredibly strong platform. I think everybody can share experiences. احنا مثلا في different parts of the US في ناس عندهم a lot of cases. Some other people haven't seen COVID-19. But for us to sit down and share these experiences, I think it's very important. رسالة ثانية للناس السودان أنا بقول لهم please be safe. Please listen to these social mitigation strategies. مهمة جدا 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 لأنه الوقاية خير من العلاج. ولو في طريقة الناس تمنع المرض من إنه يصل spreading في السودان بيكون أفضل وأرخص وأحسن. Please listen to that. شكرا جزيلا.
شكرا لك يا دكتور مصطفى. اعتقد كده بنكون وصلنا لنهايه محاضرتنا الليله. داير اشكر الدكاتره دكتور خضر عثمان شكرا جزيلا، دكتور مصطفى، دكتور احمد الكجم، دكتور خضر دلوك، وبشكر كل المتابعين. ونتمنى انكم تواصلوا في متابعه صفحه تجمع الاطباء السودانيين بالولايات المتحده سابا. نحن دائما حيكون عندنا منتجات وحلقات ومحاضرات تكون موجهه لزياده الوعي الصحي عموما وزياده المعرفه الصحيه بالنسبه للاطباء والكوادر الصحيه. شكرا جزيلا وتصبح على خير يا جماعه.